Welcome to this session on driving innovation to advance cancer control equitably in the run-up, should I say, to the UICC's World Cancer Leaders Summit 2021. I'm Charles Goddard, I'm Editorial Director at the Economist Group, and it really is my great pleasure to welcome Ian Frazer, an immunology professor at the University of Queensland in Australia, and the person who created, along with colleague Dr Jian Zhou, the HPV vaccine, which prevents cervical cancer. Among many notable contributions, Ian is also a long-time advisor to the Australian government on medical research and innovation. Welcome, Ian, to this brief discussion.
Good to speak with you, Charles.
I thought we'd begin, Ian, with what else but COVID-19 and the fact that highly effective vaccines have been developed in record time to try to deal with this pandemic. I wonder, what does this extraordinary, what I'd say is an extraordinary innovation, tell us that we could be doing better, not just for viruses like COVID, but for the development of vaccines and treatments for other pressing public health challenges such as cancer?
Well, look, we've had the great advantage that over the course of the last 10 to 15 years, a whole range of new technologies for vaccines have been developed and tested in animal models. If it hadn't been for that work, I don't think we could have possibly have got to the vaccines that we now have for COVID quite as quickly as we did. It points out the benefit of encouraging research across a wide range of disciplines, because you never quite know when you're going to need the technologies that are being developed at the moment to answer the problems that we'll see in the future.
So one of those technologies, of course, is mRNA, and the mRNA technology vaccine that's in the spotlight at the moment. Is this a technology, do you think, that could prove useful against certain types of cancer, particularly hard to treat cancers?
Yes, look, we're actually doing experimental work in the cancer space using mRNA vaccines as we speak. But the problem with the mRNA vaccines has been twofold. One is to get a safe delivery system for them, which avoids some of the side effects that were seen with the earlier mRNA vaccines. The second one is obviously this business of stability. For a cancer therapeutic, it might be quite okay to have a vaccine that needs to be stored at -80 and is very fragile. For delivering something more generally across the population, we're finding out the challenges of delivering a vaccine such as the current mRNA vaccine for COVID across the global scene is really quite significant. If you go to a country where there are no -80 refrigerators at all, then delivering a vaccine of that sort becomes a major public health challenge.
Well, let's just talk, you mentioned, of course, therapeutic cancer vaccines, of which an mRNA vaccine, which if it was developed for cancer would be something similar. But there has been, I think, for many years, there was little progress around developing therapeutic cancer vaccines, but that has begun to change, and that there is now, in a sense, a resurgence, I think, over the past several years of interest in trying to develop these kinds of vaccines. I wonder why is that, and what are we getting better at understanding around therapeutic cancer vaccines?
Well, three things have changed the scene. The first is the success of the non-specific enhancers of immune response that have been seen in many different cancers now, the so-called checkpoint inhibitor drugs. Those have shown very clearly that the immune system can deal with cancer if it's sufficiently kicked hard enough. And it has made a very significant difference for the management of some skin cancers, melanoma skin cancer, for example, where previously incurable patients are being cured simply by turning up the dial on the immune system. But that in turn then leads to the question, well, if the immune system is able to see these cancers, what exactly are the immune cells seeing? And so that's led to a whole area of research on what bits of cancer are presented to the immune system naturally, and why don't we make a natural immune response that would be as effective as we can get when we turn up the immune system. So that mapping out antigens has become possible because of the advances in genomics and the ability to rapidly determine what an individual patient's cancer cells look like. And then the third thing is that we've developed new adjuvants and ways of stimulating the immune system to work better, so that when we put together a cancer vaccine now, we can use specific antigens that are unique to that particular cancer, and combine them with particular stimulants to the immune system, which get past the many blocks that cancer erects to defend itself against the immune system, because we now understand better what those blocks are. So the whole field has moved forward fairly substantially. Having said that, of course, we're still at the stage of research for the vast majority of cancers. It's relatively easy to talk about immunotherapy for a cancer caused by a virus, such as papillomavirus, but because there's bits of the virus in the cancer. But for most cancers, every individual's cancer is different from every other cancer. And therefore, you're basically talking about personalized medicine on a grand scale to use immunotherapy as part of the management of cancer more generally.
And it's one of those challenges, also the challenge of tumor resistance that it might develop to those vaccines.
Well, you've got several problems. Cancer is very good at solving its own problems. One is that it will change rapidly, and if you limit the growth of the cancer by one means, the cancer cells will mutate to find a way of growing independently of the means that you've been applying. And that will be equally true for immunotherapy as it is for drug therapy, so that clones of cancer cells will grow out, which are immunologically distinct from the vaccine that you've been using. And therefore the therapy has to be advanced to keep up with the cancer. But we also recognize that there are more general blocks to cancer immunotherapy, where the cancer turns on some of the systems that normally switch the immune system off. And there's a very good possibility that we can get general approaches that will work across many cancers that attack these, as we're doing with the checkpoint inhibitors. So it's going to be a combination of specific immunotherapy combined with specific drug therapy, combined with drugs to turn off the blocks to the immune system. And combining all of these together will give us a better approach to very many cancers, I suspect. But we're learning now which cancers use which tricks. And once we've got a better map of that, then it will be possible to develop more specific therapies for individual cancers.
You mentioned earlier genomics, and I'll come to that in a second, but I just wanted to ask you, just in a very broad way, you've already talked a little bit about it, but in a very broad way, what excites you most now about the innovation landscape in cancer?
The fact that we're bound to be excited by the fact that we better understand what cancer is all about. We have a much clearer vision of why cells become cancerous, what the stages along the way towards cancer are, and how we can intervene practically. I mean, ideally, you want to catch cancers before you even know you've got them. And the ability to understand whether you can screen for cancer cells. There's many technologies that are coming up now where you can look, for example, for circulating cancer cells in the bloodstream, even before there's an obvious cancer present, might allow us to get to the cancer at a very much earlier stage where it hasn't had a chance to diversify and mutate to escape the various defenses that we have against cancer. We know that half of all cancers that arise are eliminated by the immune system without us ever having to intervene. And that tells us that it shouldn't be that much harder to push the system further towards interventions that will enable more of these cancers to become susceptible to our own immune system.
Well, that leads us, I think, quite nicely into this question of genomics, which does look at this question of how do you intervene as early as perhaps you can. You've mentioned before that genomics is very much an important component of the future of medicine and health. And I think many, of course, do share your optimism, but equally, I think there are plenty of obstacles and hurdles. How do you think that government should frame, and health systems indeed, should frame this potentially transformative new approach, even as it rapidly already is beginning to make headway into clinical practice?
Look, I think there's a certain nervousness in the community about genomics. It's sort of personal, and you don't necessarily want to give all your personal secrets out there. But what we have learned, and I think what has worked quite well in Australia, is the recognition of the practical application of genomics for rare so-called monogenic diseases, where the disease runs in the family and it's not clear what the basis of it is. It allows us to more clearly map out who might be at risk of transmitting these diseases forward to the next generation. But equally, it starts to lead to treatments for some of them, where if there's a clear mistake in the immune system, we can perhaps bypass that biochemically. We're not yet at the stage, I think, that the community is ready to accept even somatic cell genetic changes in individuals. That's going to be one of the hurdles that's going to take a while to sort out, not least because technically it's very difficult. I mean, it's easy to talk about, but very much harder to do. But I think that the other side of the coin is that we're recognizing that we can start to map out what gene variations put us at particular risk of chronic disease. And as we get better doing that, we'll also get better at intervening in a sensible way to prevent chronic disease in individuals who carry a higher than average risk for these diseases. It's still very much at the stage of research driving the engine. We aren't really at the stage yet where genomics is going to make us a very large impact on the management of most health problems. But the one space where it does make a difference is in cancer, because we can map out which mutations have led to the cancer and then map onto that which therapeutic interventions, which drugs are most likely to make a difference for that particular patient's cancer, and give them the best chance of survival without side effects.
I mean, that idea that somehow we're not quite ready for it, both in terms of, you know, where we are in research, but also where health systems and indeed populations are in relation to understanding and accepting genomic technologies. I wonder, I mean, Australia has been described, as has the UK, as being, as looking at genomics from the point of view of building the plane whilst it's flying. Others are much more precautionary around it, looking at sort of establishing early stage research, early stage infrastructure, and thinking through the problem rather than sort of flying whilst they're also building the plane. How would you, I mean, is that a fair characterization of what's happening in Australia and the UK? And how would you see research and health systems themselves being ready for the complexity and responsibility that goes along with genomic medicine?
Well, I think it's important to understand that Australia and the United Kingdom have taken a holistic approach to the whole problem of genomic medicine. They do research on the genomics and the practical uses of that, but they also look at the ethical aspects of it and do consultation within the community. And I think it's important that by familiarizing people with what it's all about and taking away the mystique of genomics, then you can encourage people to feel more confident about making use of it as a part of what is in effect just another diagnostic pathology test. A rather more complicated and more sophisticated one, it's true. But the idea that you're going to start engineering the genome of individual humans is one that we have to basically suppress. It's too early to start talking about that yet. It's of unproven benefit even in animals, and it would be kind of changing the nature of the human race to start manipulating the human genome for whatever reason, whether it's cosmetic or to prevent disease or to try and eliminate what we might regard as faulty genes that might in the long run lead to health problems. Because we don't understand the consequences of everything we do in that model, unless we actually try it, we're going to be very reluctant to move in that direction, I suspect. And many of the genes which may cause one set of problems actually may make us much fitter to do other things. And therefore, we're really not in a position to start meddling with our own genome yet. But just using it at a practical level for solving the immediate problem of why is this child sick, or can we understand why this patient responds to that drug for their high blood pressure, whereas they don't respond to this one, that will be useful and in due course become routine part of care, I would suspect.
Let me, before we come finally to HPV and cervical cancer, just let me ask a broad question about what we've been talking about, essentially, innovations, immunotherapy, genomic medicine, but a much broader question around the concern that some have that treating cancer with the latest drugs and the latest technologies is costly and will not necessarily improve survival globally, particularly in low middle income countries. Do you share those concerns, and are we approaching cancer in the right way across, outside of the context of high income countries?
Look, it is a big challenge. I mean, practically the very best way to deal with cancer is to prevent it. and education of the community as to what causes cancer, what risks arise from particular behaviors which would increase your chances of getting cancer, smoking, tobacco generally, alcohol, and other well-defined environmental factors that could reduce our burden of cancer is the immediate solution on a global basis to reducing the burden of cancer. Longer term, obviously, it behoves us to make sure that we have rational use of appropriate treatments for cancer. We can screen for some cancers, we can prevent some cancers arising by appropriate screening technologies, but we also need to start thinking about what is an acceptable treatment. And it depends on the circumstances. A 50-year-old with one particular cancer might very well benefit very specifically from a treatment which an 80-year-old wouldn't necessarily want to have because the side effects were greater than they would perhaps need, and the chances that the cancer would kill them, as opposed to merely them living with that cancer, would be rather different between a 50 and an 80-year-old. So it's partly public health and health economics that will drive the system, but we should be trying to make the therapies that we know work, radiotherapy, chemotherapies that we know are effective, available on a global basis. And part of that obviously is working out the whole economics of how we manage cancer generally. 1 in 2 of us will get a cancer in our lifetime. 1 in 5 of us will die of cancer. So it seems appropriate that we should put a lot of effort into getting the best treatments available to cost that the whole general population across the planet can afford, not just the wealthy countries.
Well, that issue of equity and getting it out to as many people as possible, particularly to women, is right behind this whole question of cervical cancer and HPV vaccinations. And for the first time, that's a cancer. There is a cancer that we could potentially eliminate, and there is a global campaign, of course, to eliminate cervical cancer. It's a rare innovator, I think, that gets a chance to see something that they've created being implemented, especially at scale. What are your hopes for this global campaign for the elimination of cancer, and what concerns you most, I think, after all, about what, after all, I think remains really a fundamental and really big challenge ahead of us?
Yes, we're in a very fortunate position that we have a vaccine which can, in principle, eradicate cervical cancer. But even if we deployed it globally tomorrow, it's still going to be 30 to 50 years before we get rid of cervical cancer. At the moment, I think the most important thing is to recognize that there are other ways of controlling cervical cancer that should be run in parallel with a vaccination program. So it's really important that we implement some form of cervical cancer screening in the developing world, as we do already in the developed world, make these screening tests affordable, make sure that there is actually treatment available if a screening test comes up positive. The work that we've done in Vanuatu shows very clearly that one of the major challenges is not so much getting women to take part in the screening programs, they're willing to do so, but making sure that they then follow up by getting treatment if the screening test suggests that they need it. And these women are women in their 30s, 40s who are clearly not going to benefit from the papillomavirus vaccine programs that are being rolled out. They will benefit the teenagers of today and tomorrow. And we need to do both in parallel if we're really going to control cervical cancer. Are you hopeful that this vision can be achieved? Yes, I mean, I think with Tedros and the WHO taking this on as a challenge, plus the very much better knowledge now that exists about cervical cancer globally, there's a reasonable prospect of eliminating cervical cancer within the predicted period, which unfortunately is 80 years. But it would be very nice to get rid of this cancer. And if we go about the vaccination program that we're planning globally for papillomavirus at the moment, then not only will we get rid of cervical cancer, but we may reduce very significantly the burden of one other cancer, oropharyngeal cancer, and some other rarer cancers which are also caused by papillomavirus. More importantly, it also sets the scene for routine screening for cancer more generally. If there's a valid screening test, we should be trying to deploy it on a global basis to reduce the burden of cancer. And I think just the fact that we're taking on cancer as a global problem is very important. We've done that for tobacco control. We've done that to some extent for industrial pollution and the causes of cancer. taking it on for yet another cancer, yet another cause, getting the message out that cancer is in principle preventable, at least under some circumstances, is really important for encouraging governments and general public to take part in the screening programs that are available, and to argue for better use of funding to make sure that we get good outcomes from those programs.
Ian Frazer, I hope I share your optimism, but thank you very much indeed for your thoughts. Ian Frazer, Professor of Immunology at the University of Queensland. Our thanks
Thank you for your time this afternoon.